right. Hello, everyone. My name is Whitney Pimentel. I live up here in Georgia, so not too far from Orlando. And I wanted to take a minute from Renee and I and say thank you to Camille and Robin for everything that you do for the foundation and for these families. And thank you for allowing us to be part of these families' lives. It has really been an amazing, I think 8-9 years now that I've been coming down to Orlando, and I have some amazing families, amazing stories, amazing clients. So thank you very much for that opportunity. So let's get started. I'll tell you a little bit about myself. I am a true Southerner. I lived in Phoenix for about 17 years and I did love it, but I always want to be back in the South. And so we moved back here about 4 years ago. So we're in Georgia and absolutely back to my roots because I grew up in Arkansas. My life totally revolves around my kids' sports. That is all I did. Now it's unbelievable to me still that I have 3 that are in college. My twin boys left they graduated in May. So they're in their first semester of college, but it still revolves around them coming home for the weekends, or my daughter plays soccer for Mississippi State. So you might hear my husband yell here in a minute because the game is on TV and he's going to be watching the game while I'm doing this. So I apologize. So I've got 3 kids. We've been married for almost 25 years. I'm an airline wife. He is a pilot for Delta, which works out great because I love to travel. So you can imagine how the last year has been with not being able to travel. I've had to find other ways. And so this is a great picture of Renee and I when she just came to visit me last month. And we both love to travel and we both love speech therapy and doing our travel clinics. So Renee.
Yes. Well, I'm Renee Hill and I live in New Braunfels, Texas. And I've been a speech pathologist for about 23 years now. I'm a military brat. I've moved all over the world. And I lived in Europe, lived in Kansas, lived in Alabama. I graduated from Alabama and I am a traveler too. I didn't marry a pilot, so I got a job that allows me to travel for work. And so I get my travel paid for by working as I go. So I was blessed to meet Camille and Andrew many years ago. And I was blessed to be able to travel with Sarah Rosenfeld Johnson, who got all of this started. And now I've kind of taken over some of the things she used to do and doing them. And it's exciting. Whitney and I love to travel and to Orlando and get together. Although we did get together last month in Atlanta for my first live lecture in 1.5 years since COVID. So that was exciting.
Yes.
And I've been with Talk Tools and teaching Talk Tools courses for about 20 years. So been at it a while and used to do a lot of travel clinics, and now I'm too busy. Orlando's my only one. So I kind of have narrowed that down. I have a clinic in Texas and I see clients on a daily basis. I just finished an hour ago and I think that's about it. So looking forward to meeting and talking to some of you who are new to hearing about this program. So Whitney and I chatted before and kind of decided that maybe an overview of what oral placement therapy, we call what we do OPT. Talk Tools is a company that I lecture for, and Talk Tools is where we teach a lot of OPT, but OPT is kind of all encompassing of a bunch of different things. Whitney and I have both taught and trained for Talk Tools and used Talk Tools, but we also use a lot of other techniques as well. So I think it's, when I kind of think back when I used to see Andrew, I maybe Talk Tools was about all I knew. And now we get to help parents with not only oral placement therapy, but we help with behaviors, and we help with apraxia, and we help with tongue ties, and we help with all kinds of things. So our job and what we are able to offer families in Orlando has kind of expanded as our knowledge expands. I think I can speak for Whitney. We both are continuing education junkies. We love to learn, and we love to share. So hopefully we can share some of that with you. And we're going to try and keep it a little short and sweet so that you have plenty of time to ask questions, but hopefully you'll get the idea of what we're doing down there. So first up things first, happy World Down Syndrome Day to all of our babies. Some of these you might recognize, some you won't. These are some of my kiddos from all over. Some of mine that are grown up, some of mine that are new. So we just want to say we love all of them. And it's, I think Down syndrome is probably where our heart is, and where I know when Sarah developed this program, where she made the biggest impact, and we want to keep doing that. And I was kind of looking up online today and saw that Connect was the theme for this year. And I think, you know, there's no better way for kids and adults with Down syndrome to connect with peers and the people around them through communication. And I think we play a big part of that, and we are very excited to do so. So first question everybody asks, when do I start OPT? And the answer, without even looking at the chat, is now. The earlier you start oral placement therapy, which is really anything that has to do with the mouth, the earlier you're going to establish good habits. And so we like to see babies right out of the hospital if we can. We like to make sure that they're breastfeeding well and bottle feeding well. We know with the diagnosis of Down syndrome that there's potential for low tone, and sometimes that low tone to be pretty significant. And that means that those muscles may need more help to develop. So the earlier we can start with them, the better. And I like to think about sometimes oral placement therapy as preventative when we start early, trying to prevent some of those early bad habits that develop. And I'm going to show a slide in just a minute that kind of talks about how some of that happens over time. You know, you can think about oral placement therapy as a way to help your child develop movement, just like OTs and PTs do. And, you know, again, OTs and PTs, they want to start early. We want to start teaching them how to use those muscles really quickly. And I think it sometimes lags in speech therapy. We tend to see a lot of times where a child will go to see a speech therapist and they're eating okay and they're gaining weight and they're not really talking yet. So there's not really anything to do with speech and language yet. And so therapists won't, we'll say, just wait. And we'll see them when they start talking. And what we want to say to you is that our therapy is meant to be done, if possible, before any of that speech starts to develop, before they even start beginning to eat later foods, because we can teach them how to do that better than many times they're developing on their own. So just remember that learning good movement from the beginning will help with later speech. Now, some of you are here and your child is older and you're saying, well, shoot, is OPT not for me? And the answer for you is no, it's for you too. But what we have to do as kids get older is often fix habits. And we're pretty good at that too. And we're trying to fix bad habits and create new habits. And so that's the focus changes a little bit the older you get. So I just wanted to make sure I mention that as we go forward. When we think about speech and eating, and that's primarily what Whitney and I focus on with this particular program with the foundation, is helping the mouth develop in a healthy, good way. And development is extremely important. It starts from birth. It's really important if you have young ones or you have ones that are delayed in developing speech and language and maybe even feeding. Knowing and understanding mouth development is really helpful and something that we focus on a lot as we're working with families. Our goal is to help keep your child's mouth development on track as much as possible. Think about it like exercise. We all have to exercise to some degree. Some of us have to exercise more than others to keep ourselves fit and keep our muscles the way we want them. And it's kind of the same in the mouth. We've got to keep those muscles functioning and moving in good ways to then transfer into good speech and good language and good feeding. So that's our goal, is to try and help them keep on track. And we're going to kind of show you how we do that. There's a book that I use a lot and I recommend a lot that is really pretty much everything you need to know about how the mouth develops from birth all the way through when all of these mouth muscles are supposed to be functioning at a normal level. Basically, your oral motor system, on average, if you have normal developing muscles, is intact and doing what it's supposed to do around 3 years. And we know with kids who have genetic disorders and kids that have low tone and a tough start, that can be later and later and later. But this book really goes into how you can help all of that develop. It was written for parents. So if you've never read this one and you have young kids or you have kids where you're concerned with the muscles of their mouth and how they're using them, this might be a good book for you to look at. I think somebody has a microphone on. If everybody could just check and make sure you're muted. So some of the reasons why we want to look at mouth development and how can we help with this? We look at mouth stimulation from all different angles. We look at it from feeding, because most of our kids, I shouldn't say all of them, sometimes we see kids who are not oral eaters, but there usually is some component of feeding when we look at what's happening with the mouth. Mouthing hands and objects, that's a stage that most kids should go through, and something we ask about and we address if they are doing too much of that or not enough of that. And then we have all kinds of different things that we teach for our babies as young as a few weeks old, all the way to some of our adults that we're working with, working on stimulating those muscles to be able to be more active, to do the things that we're asking them to do, whether it's eating or speaking or exercises that we might be working on. So we're going to just kind of go through some of these and just think about the different stages. So mouthing, one of the things that you might want to think about is whether or not your child is mouthing. And a lot of kids with low tone, sometimes mouthing can be a little bit delayed because they can't get their hands to their mouth as fast as other babies, or they're having other complications. But those mouthing experiences are really important, and they help facilitate later sucking and biting, chewing. They help them explore textures in their mouth. They help them learn to move their tongue around. So it's really important that we find safe and appropriate objects for them to mouth. This little picture here, he found his toes. That often happens as well. But we guide families through choosing these kinds of things and then thinking about how they're mouthing. Some kids mouth in positive ways that are producing good movements, and then other kids mouth in ways that maybe are creating bad habits for later things. So mouthing is something that we want to think about. I just wanted to put some different stages, and I didn't give Camille, I didn't give you guys a handout with this, but Camille, I will send this to you, all the slides, so you can send out to the families or put with the video. But just some of the things where a little bit of a checklist, and these are all in that book by Diane Barr that I showed you a minute ago, with some really nice checklists that you can go through for yourself. But we should see babies putting their hands to mouth around 2 to 3 months. Then we start to see them mouthing different types of objects, sucking and exploring bigger things. And then as they get a little bit older, they start to do what's called discriminative mouthing, where we're starting to see more movements. And these are some things that we're watching when we meet with babies. We're looking at those stages of mouthing, and then we're helping guide them through the stages if they are missing some of them, or maybe not able to get those toys to their mouth like another baby might. It continues to develop through 24 months. So, a lot of parents will ask, when should kids stop mouthing? And really, mouthing stops when good motor function takes over. And so some of our kids will mouth longer because they don't have that good oral motor skill just yet. But it becomes more sophisticated and more precise when they start to learn new skills. And these are some of the skills that we wind up teaching a lot of our kids, because we can facilitate good movements through blowing and learning how to drink from a straw, and some of those kinds of things that we'll talk a little bit more about in just a minute. Face massage is another good activity for kids of all ages. And I know some of you are on developmental programs, and I know there's lots of talk and lots of programs for massage, but it's really good. It stimulates blood flow. We get positive tactile experiences that can help us with later experiences with food. And we do this with a variety of textures and temperatures. And so it's again, one of those things that we want to check and make sure that your child is doing well with, that we're giving them those experiences, and we're catching any signs where maybe a child has difficulty with some of those kinds of things. I know right now I've got several kiddos on my caseload in Orlando who have sensitive mouths, and they don't like anything around their face and inside their mouth. So we're working on trying to desensitize them so that we can have better experiences later. So we have to remember that this therapy is supposed to be fun, and it's for babies and our parents and our toddlers and our middle schoolers and our high schoolers, but it has to stay fun. This type of program is not a sprint. It's not something that's finished in 6 months. It truly is a marathon as your baby develops. We have been with many of our kiddos down in Orlando from when they were very young, and you're going to hear from some of those parents in just a little bit. And we continue to follow them, not because they haven't made progress, but because every time a child moves into a new stage of development, there's always new things to be working on. And again, we're trying to guide them through that development and help them be successful with learning new things. So this is just a little video, and this is not any of the Orlando families. This is actually a little one that I consulted with down here, but it's just kind of reminds us how our interactions should be. And one of the things that Whitney and I talk a lot about, we are teaching parents to do this therapy at home. That's our goal, because it needs to happen on a regular basis. We do a lot of consulting with local therapists, but even when you have a local therapist, our goal is to train you to be a good therapist when we are not there. So I just wanted to show you a little bit of this one. This little boy, he was having some trouble with allowing some of mom's work on and around his face. And so he's doing therapy on mom and getting comfortable.
Go ahead and do what you have to do on my face. Okay, what else? Oh, it's just, mhm.
So he's becoming a good little therapist himself. And that's the goal is, we want our clients to know what we're doing and why. And most of the time they can do it as good as us by the time we get through a couple years with them. So a little more about massage. It helps. Didn't we just go through this? It helps provide tactile experiences. It can facilitate good movement of the jaw, the lips, the cheeks, and the tongue. And that's where our program kind of comes in. We take massage kind of to another level where we're really helping to focus in on specific muscles as we work on a massage or what we call pre-motor work with our clients. And it really helps them get ready for either later textures in foods or eventually being able to feel their tongue and their lips when they're starting to speak. I wanted to touch just a minute on nose breathing. Whitney and I have kind of done some more continuing education in the last few years in an area called myofunctional therapy, which is a type of oral motor therapy, but it really looks at the health of the oral motor system and the importance of our mouth being closed, our tongue being inside, and breathing through our nose, which we know can be somewhat challenging for our clients. But as we start to work with our as we continue to work with our families on eating and talking, we've begun to talk more about overall oral rest posture and the importance of nose breathing, which is critical for overall health. And when we think about babies when they're born, even babies with Down syndrome, we typically see mouths closed and nose breathers, but we see very early on in development, some of our babies start to have more open mouth postures, more tongue forward postures, and then become mouth breathers. So one of the focuses as we start with these babies or work with our older clients who maybe already have an open mouth posture and are mouth breathing, trying to teach them to do some nose breathing. It's critical for your overall health. It helps the face develop and reduce drooling. We want to be working with your ENT on helping keep that nose clear as much as possible. Some of our kids have chronic illnesses. Others just seem to have chronic stuffy noses. Others maybe just have narrow nasal passages. So really working with your ENT and talking to them about how you can keep the nose clear, sometimes with medications and a lot of times without medications, is really an important part of working on nose breathing throughout the entire lifespan. So allergies, small nasal passages, obstructions, respiratory illnesses, all those things encourage mouth breathing. And those are things we want to try and avoid as much as possible. Another part for kids with Down syndrome is that the jaw often is weak as part of their overall weakness of their entire body. So we do a lot of jaw work to help our clients maintain a closed mouth or develop a closed mouth if we see them and they already have an open mouth. We also want you to know that some of these things that we hear about through our doctors and other families and Google searches are things that we call the myths of Down syndrome. And we call it the myths, not because we don't see this with kids with Down syndrome, but because there's an assumption sometimes that that is part of the diagnosis and not something that can be corrected. I work with kids all the time who have doctors who still to this day will say that large tongue is just because they have the Down syndrome and there's nothing we can do about it. And we call them the myths because we recognize that through good oral motor work and oral placement therapy and mouthing and mouth development and good feeding, these things that we don't want to see with Down syndrome or with anybody, we can often prevent if we start early enough, or we can correct if we start later. So open mouth postures, interdental tongue postures, and the large tongue, those are all often contributed to some of the issues that we are addressing, not because they're structurally part of Down syndrome, but because when your mouth is open all the time, and you're having trouble breathing because your nose is blocked, so this fourth one down here, upper respiratory issues, and you're having to breathe through your mouth, your tongue sits low and it doesn't stay in what we call a toning state. So if I looked at everybody's video camera, I would probably see that most everybody has your mouth closed while you're listening. Your tongue should be resting up on your palate. That's our natural resting posture. Your teeth should be close together, but not touching. Your lips should feel relaxed, but they're closed, and you're breathing through your nose. And that is a normal oral rest posture. And that is a toning state of your mouth. Even though you don't feel like you're doing anything, your muscles are active. And when your mouth is open, your mouth is in an inactive state. And so this inactivity that we see with a lot of our little ones with Down syndrome, causes these things to occur. So as we work on oral motor skills, large tongues can become smaller because they become more toned. We teach them to breathe through their nose so they have less upper respiratory problems. High narrow palatal vaults, this is not something that we can fix in therapy, Whitney and I, but we do look for them. If we start with our babies, sometimes we can prevent them from becoming too high and narrow, but a high narrow palatal vault doesn't allow for space for the tongue. And if the palate is too small, the tongue can't sit where it wants to. So our goal is to help your babies maintain a good palatal space. And we do that through some different exercises and things, and trying to help them be a better nose breather. And then with some of our older ones, working with orthodontists to work on palatal expansion to make space for that tongue. And you'll hear from at least one that I know who's in those stages of their oral motor program to help her daughter get to the next step of having good oral rest posture and good speech and good eating. Okay, so that's a little bit about mouth development. Whitney is going to tell you all about feeding and what we like to do there.
I almost forgot to unmute myself. I muted because I told you guys you're going to hear my husband yelling, and he has been yelling. All right, I'm going to talk to you guys just a little bit about feeding and why it's an important component of our oral placement therapy. It's still interesting to me. I've been a speech therapist for, 26 years now. I've been doing oral placement therapy for the majority of that. And feeding was a huge component for me. And it was one of the reasons that got me into oral placement therapy, because I saw this huge disconnect with clients that I was seeing. And I was like, wow, your speech is not developing and you're drooling and you have all of these delays, but you're also not eating. And the more I learned and took a lot of continuing ed classes, it is a very important component of development. It's also obviously nutritional concerns. We want to make sure that our kids that we're working with are getting the adequate nutrition that they need to develop. But the muscles that are used in feeding are also the same muscles that are used in speech. So what happens when we have you all come in for the evaluation, we give you a list of suggested foods to bring. And it's happened so many times where they're like, why do I need to bring food? My child eats, they eat just fine. But then when we show them the specific movements that we're looking for, the parents are like, wow, I never thought that I needed to watch to see what they did with the food once it goes in the mouth and how the tongue moves and how important it is for the tongue to retract and not go forward. So there's many different activities, and I'm going to get into those on the next slide, of what we need to be doing to watch for that development. What do we do if the mouth isn't developing normally? Well, we start looking obviously at oral placement therapy. There's a great book that Lori Overland and Robin Merkel Walsh have written. They're colleagues of ours. They work for Talk Tools, and they have developed, Lori has a great sensory motor approach to feeding class that she teaches. And I have learned so much from them regarding looking at the mouth and the development. So we have the oral placement therapy program, and then we have a pre-feeding program, which helps the muscles develop and gets them ready for later feeding skills. So this pre-feeding program, these are exercises that we will do with clients as young as 1 month old. And before that, I mean, if I could get them at 2 weeks old, I would take them. But we are doing these activities as getting the muscles ready for the movements that they're going to need once they do start feeding in solid foods. Then you have the feeding program, which is going to help the child develop normal feeding movements. And we have therapeutic feeding techniques that we're doing throughout that. And obviously the primary focus is going to be for safe, nutritive feeding and overall mouth development. So when we're feeding our babies, we want to make sure that when you're holding them at an angle where their ears are above their mouth. And the reason for that is if you're holding the baby down, first of all, the liquid could be going into their mouth too quickly, and it could cause them to choke and have an episode of choking or gagging. But also the milk can sit in the ear canal, which could then start causing chronic ear infections. And so we want to make sure that we're holding their ears above their mouth in a good, stable position. But it also helps them to work against gravity. So they're having to work on retracting their tongue when you're holding them up at this angle. So we help with the positioning for bottle feeding and breastfeeding when we're working with our babies that are still needing help and families that are needing support. Seek help from a trained professional. There's great lactation consultants that Renee and I have both learned a lot from, but definitely seek help from a trained professional if you are having difficulty with feeding. And I refer to my lactation consultants because they do give some great advice and they give great tips, and they can really teach you different ways to feed your baby. Feeding your baby is very important. It's a great bonding time. And I've had so many families come to me, and that is their main concern. I just want to feed my baby. And of course you do as a mother. It's such an important time and such a great time to spend with them. And when they're having trouble eating, it stresses you and it stresses them. So definitely seek that help if you need it.
I was going to throw in here, because I forgot to put it in the presentation, baby-led weaning has become really popular. And recently, Lori Overland, along with another feeding specialist who's actually an IBCLC, they've come up with a modified baby-led weaning program for kids with special needs, and primarily developed around kids with Down syndrome, to help balance that desire to let babies do their own thing with developing good oral motor skills. So it's something to consider as well.
Thanks, Renee.
Right.
So then we get into purees, and we start looking at spoon feeding and how these babies are eating the puree. The placement of the spoon is very important, because the placement is going to determine what the mouth does. So the way you're putting the spoon in the mouth is going to tell me a lot about how your baby is eating. Is the baby able to use their lips to retrieve the food off the spoon, or are they using their whole mouth and their gums and their tongue and they're pulling the food off that way? We are really looking at how the child uses the lips. So lip closure is very important. And when we start getting into speech development, which Renee is going to talk about here in a little bit, we need lip closure for very early developing sounds, P, B, M, E, and P, B, M, and W a little bit. So you have to say wah. You got to put those lips together. So you have to have that movement and looking at that movement and teaching it. So we start with the side placement where we're touching the angles, the sides of the lips to get that lip closure. And then we switch to a front position, and that's going to help with that lip rounding. So you've got that pointed tip at the lip midline there. Now we go on to cup drinking and straw drinking. Again, cup drinking, teaching them how to drink from an open cup. These are great cups that we use. They're called cutout cups or nosy cups, and you hold them, and so you can see the liquid, and then you can squeeze the cup so they can put their lips on the cup. You want to make sure that they're using their lips on the cup and they're not using their tongue. A lot of times our kids are sneaky with that tongue and they'll stick it underneath the cup to use it as their bottom lip. So you want to make sure that you're giving them some support, as you see in this picture. There's also a cup called the purple, the recessed cup, and it's got a recessed lid on it. So it's got two handles on either side so the child can hold the cup at midline. This is for more independent drinking, and they've got little holes in the cup and they can tilt it and that liquid doesn't come pouring out, but they have enough there to get their lips around the edge. There's lots of great cups out on the market. Just be really careful that you're not trying to promote sucking from a cup or biting on the cup to get the liquid out. We want to make sure they're using good lip closure and that they're holding the cup at midline.
Do you want to mention about sippy cups?
Oh, yes, thank you. I didn't know if it was on the next slide.
It's not.
Okay, yes. So we really believe in the development of a mouth, that the sippy cup is definitely not a good option for our children that have difficulty with mouth development, and especially our Down syndrome kids. The reason is because what it does is it promotes a suckle, and the suckle is what you have when you're drinking from a bottle. So transitioning to a sippy cup does not change that movement. So it's still getting their tongue to go forward and draw the liquid out of the cup, as opposed to a complete retraction of the tongue, which is what we need at that stage. Once they wean off of a bottle, and I've had some wean off as early as 9-10 months, because we switched to what we're going to show you here in just a minute, a honey bear. And once we switch them to the honey bear, then we're getting retraction of the tongue so that we aren't worrying about that forward posture of the tongue and the tongue coming forward for drinking liquids. So we really encourage our families to stay away from sippy cups. I know it's difficult. We're all on the go, we're all moving, but you're going to see through this program some great options that you would have available to you. And the straws and the open cups are awesome options. So we start off teaching all children how to drink from a straw using what we call the honey bear with the straw. The honey bear is great. You can control the flow, and you're going to see a video here in just a minute of a little girl that we taught to drink from the straw, Sarah Rosenfeld Johnson. This is a video that we have all used. Any of us that have given a presentation for Talk Tools or worked with Talk Tools, we know this video very well. But we teach a very young baby to drink from a straw. So it can be done. And then you go into the muscle work, and we have a whole straw drinking hierarchy that Talk Tools, Sarah Rosenfeld Johnson, and Renee, all of us, they created the straw drinking hierarchy. So you have 8 straws in this hierarchy, and you're going through the hierarchy. Each straw is a different, am I jumping ahead, Renee?
No, I accidentally hit a button. I'm sorry.
Okay, no, you're fine. Each straw is a different length, it's a different diameter, and we're working on a true suck. A true suck is where you use your lips. You are not putting the straw past your teeth. You are using your lips to draw the liquid up. And as you draw the liquid up, the tongue retracts. So as the tongue is retracting, we're working on the stability of the tongue, and then we're working on side spread of the back of the tongue, which are all movements you're going to need for speech sounds. So here's the video I was talking about. This is Annabella. She's 7 months old. This was a family that I don't remember the whole story, Renee, so correct me if I get any of it wrong, but begged and pleaded for Sarah to come see their child. They had heard about Sarah's work, and they just had to have Sarah. And I think there was a story about a train, but it's a long drawn out story, but it's a great story of how this family was like, we will do whatever it takes, but we've got to get this baby's tongue in her mouth. So here she is at 7 months old. I'll let you guys watch the video.
It's okay. I like how you do that. That's lovely how you do that. If I have to, I'll go back.
Okay.
I really like what I did up there. Want to feel it first? Okay. What isn't it? Oh, I'm squeezing.
Okay, I was gonna say, my God.
Good, isn't it? He was almost sucking that. That was really close. I'm sorry, I didn't mean to scare you. He was sucking on. You're very close to this, my friend. You're very close. Need some more? No, it tastes good. This has never happened in any
She's
session.
extraordinary this time.
I'm serious. I
She
have
is
never
extraordinary.
seen this happen before.
Yeah.
I am a food prodigy.
And look how her tongue is back.
Is she sucking?
I'm not doing a thing. Miracle video. Okay, have a seat.
So you saw at the beginning, she was using a syringe. It's a small little tuberculin syringe, no needle, obviously, and she's got the milk in it, and Sarah's squirting it into the sides of the cheek so the baby can feel, oh, this is the milk needs to go back here and help the tongue retract when it goes into the cheeks. And then the honey bear, you can control the flow. So you're squeezing the liquid into their mouth and they can feel it. And then they begin to get the mouth movement needed, and the suck then comes quickly after that. So here is a little girl of Renee's on straw number 4. You can see all the fun shapes and twists. These straws were developed. These are not just fun straws that are bought at the dollar store. There is a specific hierarchy that we use to promote the tongue retraction and stability that is needed. Is this a video, Renee?
It's a video. Yep. It's just a video to show you how, as you move through the hierarchy, you get more muscles working. So Esther knows how to drink from straws just fine. We're using straws now for her exercise. Esther, do you want water? Water. Water. And that's it.
Good. And then this is straw number 8. This is the last straw in the hierarchy. And if you can tell from the picture, and it is a video too, right? Isn't it, Renee? You'll see it's a very long straw. So as he's sucking the liquid and drawing that liquid up through the straw, his tongue has to retract and it has to hold in a stable position, and he's getting back of tongue side spread, which is the position. If you say E, that's where your tongue is. You can feel the back of it on the molars on the back, and that's how you get your sounds, your R sounds. That's the movement that's needed. So let's watch this video. Maybe. So he still has a little bit, something on the tip of the straw there, just as a little tactile reminder not to put too much of the straw in his mouth and to only use his lips. And if you watch, you can see all those muscles working, the cheeks, the lips, the mentalis muscle here underneath the lip. And then obviously the tongue.
Okay.
I guess it's pretty long. I think you get the idea.
I was wondering how many sips we were gonna watch.
Keep going. But that's how exercise works. Lots of repetition.
Lots of repetition. So solids, as we move to solid foods, we're going to use tools to teach the skill before we actually introduce the food. So we're not going in as therapists saying, oh, well, let's try this movement. I'm going to give you a Cheerio when you don't know how to chew. That is not safe. And so we don't use foods to teach the movement. We use different activities. So first, depending on the age, we'll use a gloved finger. And then second, we would use an infident, which adds a little bit of texture. I only use these two if they don't have any teeth. Once they start getting teeth, my fingers do not go in their mouths. I will let you as mom do that if you trust them, but I won't put my fingers in their mouth. I've been bit too many times. But you can start these as early as birth. With the glove finger, you're just rubbing on the gums and giving some stimulation, giving a little bit of pressure down, trying to stimulate that munch chew. The infident, adding texture because it's got a smooth side and then a side with a little bit of bristles. Then we'd add an ARCS probe that will help you teach the munch chew because they will want to start munching down on that. Again, thinking about what Renee talked about earlier with mouth development and how important that is. These are all skills you should start to see, but now we're going to start making it an exercise and an activity so that we then, fourth, we're adding the Talk Tools bite tube hierarchy. This is where we really work on strength and tongue lateralization. This is really one of my main exercises I use with my kids to work on strength. You don't need a lot of strength for speech and feeding, but you do need adequate strength for those activities. And when you've got a child that has a diagnosis of Down syndrome, you know we're dealing with low tone and a muscle system that can be difficult to stimulate and difficult to get going. So they need these activities to be able to help them gain the strength that they will need for feeding and speech. Here's some pre-chewing work that I did with one of my little girls in Orlando. This is an Orlando client. I started with her obviously when she was a little bitty baby, but this is some of the pre-chewing work that we did.
That feels good, huh?
Nice work.
This one's ready. Feel it's cold. Ooh, that's cold. Yeah, it's cold. Let's do that. Good job.
And then she's like, okay, I'm done. It does take quite a bit of work for them and their muscles do get tired. So you will see that as they start to do these exercises, and you will see their strength improve and their ability to chew foods longer. But there she was working on that pre-chewing work before we introduced solids. Then as our clients show us that they have the ability and the strength to be able to chew foods, it would be very important to place those foods on the back molars. So we teach the child how to do this and we teach the parents the tools to use. So you would take a small cocktail fork and you would be placing the food on the back molar. The reason for that is it completely takes the tongue out of play when they're chewing. And that way the food goes right to where it needs to go and they don't have to move the food with their tongue. That is a skill that comes a little bit later, but as we're introducing food and starting the chewing, we're giving them the placement. So then all they have to do is chew and swallow. And the tongue shouldn't be mashing the food or moving forward while they're swallowing. We do a technique called big plate, little plate. So there's a therapy plate and then the food that they can eat on their own. So these are for some of our kids who have difficulty and don't want to do it or refuse to do it. But it's also fun to show them, hey, this is your therapy plate. Here's the food we're going to do therapy with. And then you've got the food that they can finish eating their meal in their habitual pattern. You don't want the whole meal to be work. You want feeding to still be fun. And if the whole meal is work and exhausting and stressful, you don't want to create that type of environment for feeding. Feeding is supposed to be social and fun, but we want to, in the process, teach them how to be eating correctly, but also preserving nutrition. If the whole meal is work, you could start to interfere in their nutritional development and what they are getting, because they will start to refuse food because it gets too exhausting. So we have the therapy plate, and then we have the plate where they can finish the meal in their habitual patterns and still enjoy that feeding time and family time. All right, Renee, I'll let you finish up with motor development and speech.
Okay. We did have one question pop up in the chat that is a feeding question. So I'll just, the question was, does breastfeeding help with oral therapy? This one does not do bottles at all and is a great breastfeeder, but his new sharp teeth don't help.
Yes, I wouldn't think that would help. Breastfeeding is great. It is great for oral development. There are just some families that have difficulty, and some babies that had difficulty being able to get the milk. So yes, it is great for development for our babies. I would say with the sharp teeth, you probably want to start looking at transitioning to the Honey Bear and seeing if you can get some liquid in that way. How old did she say the baby was?
Didn't say.
Okay. But I would start looking at transitioning to the Honey Bear so
He's
that
one.
he's one. Okay. Yeah, definitely the Honey Bear then. Anything you want to add to that, Renee?
There's no reason that you have to go from breastfeeding to a bottle. That's kind of a cultural misinformation. So at 1 year, we could go directly from breastfeeding into a Honey Bear or a cup. Another question, my son is 17. When is it too late to do this therapy and it be effective? There really isn't a too late. The older kids get, it's more about their willingness to practice regularly. So I have evaluated and had amazing success with 40-year-olds with Down syndrome who had no oral placement therapy previously, and they did fantastic. And I have teenagers that start. Teenagers can be interesting. Teenagers have a mind of their own. You'll hear from a teenage mom. There has to be some motivation for them, and so sometimes where the goals are a little bit different. When we're working with teenagers, I have a couple of them. One, the goal, she wants to sing. And asks if oral placement therapy is going to help her sing better. And absolutely, it's going to help her sing better. And we remind her that all the time. And then I have another older young man in Orlando who is in drama and is in plays. And so we are doing oral placement therapy, and it's all revolving around his plays and him being intelligible in his songs and his speaking parts and things. So we just have to kind of get creative in those middle years sometimes if they're not internally motivated. Okay, so as we kind of look into motor development, I'm still watching the chat, and we'll get into some of this as we go, some of these questions. When we think about what oral placement therapy is, we are really assisting with the foundational skills that are needed to teach clear speech. So for Claudette's question about speech and speech intelligibility, we've talked about feeding. Feeding is just one of those oral motor skills that helps us normalize muscles. And a lot of times we are doing feeding only for speech. They eat fine, they eat everything, but they don't eat correctly. They don't have good tongue mobility. Their lips don't move independently from their jaw. Their jaw is weak. And so we can use food as an exercise to help our clients develop those foundational skills. So everything that we do in oral placement therapy, all the way back to a good breastfeeding position or a bottle feeding position or breathing through your nose, is all with a speech goal in mind. And so our program is designed to help us evaluate each one of your child's oral motor systems that are used in speech. Your palate, your soft palate moves, your cheeks need to move, your tongue needs to move, your lips need to move, and your jaw needs to move, and they need to all do that independently. And that's what we call, that's kind of like the house for speech. And if that house isn't strong and stable, speech intelligibility can go down. And this is why a lot of kids with Down syndrome are not successful with traditional therapy beyond a certain point, because it doesn't look at the motor system. So, you know, one of the things that we always see with families who come to see us, or families who are frustrated in therapy, and a child doesn't want to go to speech therapy anymore, speech therapy isn't working. Normally it's because it's not at the right level. Speech should be fun. It should be rewarding. We should be able to see progress. And we do in OPT, because we stay right at the stage that the client can do, and then we're trying to get them to that next step. And so many times our clients like what we're doing. I won't say all the time, but many times. So we in oral placement therapy are assisting with that motor development that may not be developing in a normal pattern. And we have all kinds of tools to facilitate that, whether it's tools that are helping with jaw stability and jaw grading. Your jaw is your foundation for all speech. And if most kids who are unintelligible either aren't moving their jaw at all or are moving her jaw too much. So we want to try and work on teaching them how to move in the appropriate range with the right skill, with the right amount of movement. We have tools that we use to work on lip strengthening and lip closure and lip rounding and all the things that the lips need to be able to do for speech. Cheeks are important. We don't really think about cheeks as a part of speech, but cheeks should be active in speech. They stabilize our jaw, they stabilize our tongue, and kids with Down syndrome have a hard time activating those cheek muscles. We do tongue work. Tongue. Lots of work trying to get the tongue to move independently from the rest of the mouth. And then abdominal grading work. Speech relies not only on your mouth to be able to move well, but you need to have air for speech. And you need to be able to control your air so that you can put lots of words together in one breath. And so we do a lot of work with abdominal grading. And we're often doing that alongside of what OT and PT are doing as they're working on core stability. We're just taking that stability and teaching them how to use it for speech. And then we always have to remember that we have to work on speech. Oral motor work by itself doesn't make people good speakers unless we are able to start early enough and that child follows normal development. Sometimes we don't have to teach sounds specifically. Sometimes we don't have to correct sounds. But we work with a lot of children who learn speech in different ways. And if you're in speech therapy now, many of you might be with speech therapists who only use what we call the auditory and the visual system. And that's the look at me and say what I say approach. See it, watch it, copy it. But many of the kids that we evaluate as we start moving into speech, we recognize that system doesn't work for them. They don't know how to learn speech from there. And so OPT adds a tactile component. they are able to feel it. And so all of these things that we've talked about up to this point are to help get that foundation ready for movement. And then we have techniques to help transition it to speech if they need that help. So in these pictures, you see us using tools while we're making sounds to help them feel the difference between lip closure for a p sound and lip rounding, ooh, for a round sound. It helps put their mouth in the right position. We are both trained in working with kids who have different types of motor speech disorders. And the ones we've kind of been talking about so far are muscle weakness that we see a lot with kids who have low tone, but some of our clients are going to have motor planning issues or apraxia of speech. And many of them need a little more work to get that system going. And so we're working on those things alongside of working on that motor system. So we're using tools, we're helping teach them imitation, and then we're moving into using that for language. So we might have them practicing a sound. I can't remember if this is a video. Let's see, it is a video.
Ooh,
Uh-oh, they're all going, hold on.
ooh, ooh. Good job. One more.
Good. So in this little video, Esther up here, her oral motor skills were actually pretty good by this point, but her speech just wasn't coming in. And we could tell she was very bright. She loved to use sign language, but she just could not get those sounds out. And then she couldn't figure out how to put them together. So we're using some tools here to help her copy, listen, make those sounds with us as we're trying to teach her how to say poo as a syllable. Here's another one down here. She was doing boo.
Good.
There, she refused to finish it. And then here we're doing a little bit of requesting. So once we start to teach some of those sounds, we use those sounds.
You say more? Bubble or water?
So now, if you see here, when we're trying to get her to say something and ask for something, we're not really clear what she's wanting to ask. And I'm giving her I'm modeling some words for her, and then the words aren't coming out right. And that's where this tactile approach is really helpful. We can start to help shape those things as we go. Here we are, as Esther got bigger and got more skills, we started to move from sounds to words. And you're going to see that we use some different things to help her put those sounds together and use them to describe things. So here, I'm going to do something called prompt. Prompt is a technique where we use our hand to facilitate sounds. You saw me using tools. We want to move from tools away from tools, and we're using our hands here. You're going to see I'm using a little microphone to help facilitate her imitation here. So you can just watch a couple of these.
Yeah. E. E. Oh, put that one. That's one day. Oh, good job. That's what I want you to do. Bye. Bye. Oh. Oh. Ow. Yeah. Oh. What did that say? Oh.
So now she's moving into more imitating, and imitating is really important. That's how kids learn. And that's how we can shape their speech into better speech. And so we spend a lot of time teaching our clients and our parents that we work with strategies to help them copy and copy well. One thing that research tells us is whatever is practiced is going to be learned. And so our goal is to try and minimize bad practice or errors in your practice and increase good practice. So even though I had to sometimes break a word down when we were trying to say moo and she was saying it completely wrong, saying and then saying ooh helps her mouth remember those movements better versus her just saying ba 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 ba, and I don't have anything to do to help her. So we do a lot of teaching how to help shape that speech. And then I don't remember what's in this video, so we'll just watch it and then I can give you a comment on it.
Toby. Up to next. So. B. Toby. Say toe. Say toe. Say toe. Listen. Say toe. B. Toby. That one may not make any sense to your name.
So this is a set of cards that follows some patterns. And so some of our kids maybe struggle with developing good, clear speech in language or in the natural environment. And so we have materials and we have different sets of cards and different programs that help us break speech down into easier parts or easier words and work up through normal development. If you've ever heard of the Kaufman program, we use her program a lot in our work. And here she's doing a little bit more. We're working on some more imitation.
D. Po. Bunny. Pony. Po. 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 Thank you. You said po? Knee. Yeah. Why I don't use props very much.
Oh, whoop.
Knee.
I don't know how to get one to start and one to stop. There we go.
There it is. Good. Ready? No. Yeah. Okay. Done with those.
One thing when you're working with your kids, just to think about is having strong syllables is really important. So what you see Esther working on here is not only words, but also small syllables. The clearer and more precise your small syllables are, moo, me, my, mo, boo, be, by, bo, the clearer they become when we put them together. So we do a lot of drill work with that as well. And here she is a little bit later, just so you can kind of see a progression if you work through some of this kind of therapy.
This is CD1, CD2. Baby. Good job, Daddy. 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 Yeah, that's a hard one to change because you're used to that. Mommy. Hey, oh, Mama. Bobby. Papa. Bobby. 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 Good job. Nani. 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 Yeah.
There you go. That's what maybe we're do one.
Paddle. P. Second. Poodle. Good job. Poodle. Poodle. Heidi. Heidi. Heidi.
All right, so I think you get the idea. Our program takes our client through each one of these little steps and helps them develop each component of speech until they can combine more and more and more things together. Here's another little video. This is a little guy who has Down syndrome, but also pretty severe apraxia. He had trouble getting his voice to turn on. He has trouble with different kinds of sounds. So here we are using some of our tools in early stages for him. And then I want to show you just a little bit later what he's doing, just so you can get the idea of how a tool can help get things going and create good speech habits and how we can transition that.
Good job.
Now it's his in sound.
Yeah, one more time. One more time.
That was Brody's response to everything.
Try again. One more time. Last one. Last one.
So that's where he started. And then this was here. This was probably 6 months later, maybe.
A, B, C, D, E, F, G, H, I, J, K, L, M, N, O, P, Q, R, S, T, U, V, W, X, Y, Z. You say Z?
And I just want to say, you know, you might be looking at these, and these are all clients that these are 2 clients that were in my clinic. These are parents who did this. Whitney and I just give you steps. We are not the therapists, even for our clients who come see us on a regular basis. You are the therapist, and it's our job to give you the right step at the right time. And these kids make progress because their parents work with them on a regular basis. And in the last few years, you know, this program grew from us coming once a year to coming twice a year to now we're able to support you on a monthly basis in teletherapy. And that's the goal of teletherapy, is to really keep you motivated and moving forward on your program and new work as they get better. So I was just going to show you one more little video. This is a little girl, and then we're going to have time for questions. And I see some more questions coming up. If you do have questions, just put them in the chat and we will be sure to get to them. This is Annabella. This is the little girl that you saw drinking from the straw at 7 months old. And a little backstory. So Sarah did her initial evaluation when she was a baby. She saw another therapist, Lori Overland, after that for some more feeding. She probably had the biggest, longest, low-tone tongue that we have ever seen of any child with Down syndrome. And I can still say that 20 years later. I met her when she was 2, and she had better oral motor skills, but she was still nonverbal and not speaking. And this is, she's probably one of the kids that taught me, and now I talk a lot about the importance of starting speech practice really early, along with oral motor practice, because there's no telling when Annabella would have actually started communicating with us, even with good oral motor skills. So I just want to show you a couple little videos of her. This was her at 17 months. This is her local therapist. Annabella did not live where I lived. I went and saw her 2 or 3 times a year, and I trained her therapist. to work with her on a regular basis. And then I came in, much like we do in Orlando, and updated her program. And then the therapist and mom would carry out her program. So here's a little bit of what she was doing. I'm probably going to fast forward a little bit of it. It's a little long, but I'll just point some different things out.
Please sit down. Thank you.
This is
One.
a little bit of a pre-motor program to work on getting speech movement.
Nice job.
It was the only thing she would vocalize on.
Oh, very nice. 1, 2. Nice work. Let's do one more time. 1.
It's vibrating. She liked vibration. That was her speech sound. And she had an oral motor program that she did. They did some chewing,
You put a little bit more on. Just in case.
some pre-chewing work.
Bite, 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 bite.
She had a very weak jaw.
Okay, now let's bite. Ooh, good girl.
Her chewing of foods was not really good.
Good biting.
So we had to teach her to chew.
Good bite.
By 17 months, you should be able to easily bite up and down on this little tool.
Sunday, Monday, Tuesday, Wednesday.
All right, I'm gonna fast forward just a little bit. She's gonna do a lot of that. This is another one. This is just a different diameter and a different resistance.
Oh, that's a good one. Let's try it one more time.
Okay. She's also doing some blowing work, teaching her how to blow on command, working on lip rounding and abdominal braiding.
3, 4. 2 more. 2 more.
She's blowing some bubbles.
Let's do some more.
Teaching her how to control air. And then she's doing a little bit of horn blowing. It's another tool that we use for blowing.
Let's try. Oh, got my hair, got my hair. Let's blow this one. Good job. One more time. Good job. Now let's do this one. Good try.
Okay. So lots of oral motor work happening and not a whole lot of speech yet. So when I met her around 2, I feel like I just skipped it. No, okay. When I met her around 2 years of age, we kept her going on our oral motor program because she needed, but we added some speech work to it. So here she is, she's 3, and now she's working on some different speech things. So you can see some of it. This is about 1 year later.
3, 4.
This is some of her pre-motor work.
9, 11, 12, 13, 14. Good job. We're gonna do. Karen, so Karen can see. Karen needs to see. We'll do one time. Just one. Here we go. Kiss. 1, 2, 3, 4. And then in the middle. 5. Oh, yeah. 9. She's getting 4. Oh, and a 5. Warum ist sie freigelegt?
I'm gonna fast forward this. Doing a little work on her tongue. This just gives you an idea what an oral placement program looks like.
Bite. Bite. It's good. Bite. 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 Bite.
Right, there it goes.
Tickle, 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 tickle. And we're gonna do bite, bite, bite. See you, Jules. Bite.
And let's move forward just a little bit. Doing a little better with the biting.
Good
So
job.
here we're actually trying to work on getting her tongue to move more.
Whoops.
All for speech. This is all to help her with her speech and her eating, but her speech is the main priority for her mom.
Tickle, tickle.
Let me get to the speech. Oh, this is her OP. This is all OPT. I'm sorry.
Bite, bite, bite. Good
All right,
job.
one more. Here's her speech. I forgot they were separated.
I am ready. I am ready. You're ready? Oh, boy. Up. Up. Bath. Good. Bath. Good. Good girl. Yeah. Cow. 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 Cow.
So this is all prompts to help her shape her speech and make her say them better.
Good.
We're teaching her the movements that she needs.
Duck. Duck.
Okay, so I think you get the idea there. All right, so what we would like to do, I'm gonna end there as far as what we were talking about. A couple of questions that popped up under speech, Whitney, I'll answer, and then we can maybe let some of the parents say something. A couple of them have chimed in on the chat. The 17-year-old, my speech therapist says my son is too old to really make much progress with his speech. And that's kind of a frustrating statement. And I have to say that this type of therapy is not known by everyone. And a lot of us that come out of school don't know how to help somebody who is not learning through traditional methods. And I think maybe that could potentially be where that speech therapist is coming from, is based on what she knows. There's not maybe much more that she can do, but I would second what Christine and Karen both said, is that, that it's never too late. Does it take more effort as kids get older and habits are established? It can, but a lot of times just having the right program at the right time. I work with many, many, many children who are nonverbal, non-imitative, have no words, and through this program, we've been able to see some really nice things happen. So I would say, don't give up, and come see us.
Yeah, I definitely second that. I've got several on my caseload that came to me at 12, 14. I have one that came to me at 17. And it is frustrating as a speech therapist to feel that you don't know what else to do. And this was my main reason for getting into this type of therapy and expanding my knowledge there, because that's not a fun situation to be in. And so it sounds like this therapist is wants the best for them and is doing the best she can with the knowledge that she has. So I definitely would recommend that you come see us and get him on a program plan.
Camille, how did you want to facilitate letting some of these parents?
I think can we have the parents that you guys have who are using the program speak, and then we can go into the questions. Would that be okay?
That'd be great.
That's fine.
Who wants to speak first?
Soren or Josephine?
I can go first.
Yeah.
Hello, I'm Josephine. So that's my daughter Mila on the screen. We've actually heard of Whitney and Renee through the foundation back when Mila was only 3 months old. So we went to an event like this. It was actually in person because it was pre-COVID, obviously. And so at the time I was like, we need to do this. Like I knew at the time that Mila needed this because nursing was difficult. And then we tried bottle and it was the same way. And I just knew that she was going to have a hard time. So we started pretty soon after. I think Whitney saw her when she was about 6 or 7 months old because we had to wait for them to come back and do their evals all over again. And on her first visit, she did her eval and she pulled out the honey bear and it worked. I saw her use the honey bear on her the first time and she just started sucking from a straw, which was something that I have an older son. My son didn't even like learn how to suck from a straw until like way later. So for me to see that with my daughter, and she was only like 7 or 8 months at the time, I was like, okay, we have to do this. I was already committed to the program, but I was like, this is gonna work for her. And I think Renee had mentioned something about one of the moms on the videos. Her whole reason for doing this was her speech. And I could say the same thing for myself. I really want my daughter to have those skills and those like that foundation in all like her oral motor muscles to be able to articulate properly so that people can understand her. You know, I don't want her to have a hard time communicating. And so I can see how all of this is laying the foundation for that. And like everything that we do with the pre-feeding also has helped with her feeding along the way. We've done things with we do the straw kit and the horn kit also with her. And I just see how it really works, but you do have to put in your effort as a parent at home also. So your therapists are there to facilitate all this and to guide you through it. But if you don't do it at home and you don't follow through, then you're probably not going to see as much progress as you'd like. And so that's a big thing for me. Like in anything that we do with Mila, we do, you know, parents with our kids with Down syndrome, we do a lot of PT and OT and speech. And so I realized that with her, you really have to follow through in any of these disciplines, specifically in OPT. This is an area for her that if I don't follow through, she's gonna regress. So it's definitely one of our priorities to work on from week to week. And I definitely recommend it. I think it's really, really amazing. We don't have enough, I think, therapists that do this kind of service for our children. So that's what I wanted to say.
Thank you, Jessica.
You're welcome.
Karen, are you on there?
Yeah,
Yeah,
who's
go ahead, Soren.
Should I go?
Go ahead. Yeah.
Hi. So we started, I think right after Luke was 1 year old with Whitney. And I remember I heard about Talk Tools when the year that, the next year that Luke was born, the Down syndrome convention was here in Orlando. And then I remember Camille was there, and Camille told me, "Oh, we offer that program to the foundation." But Luke was nursing really good. We breastfed for like 3.5 years, so that was good. The problem was, I thought I did not need it. I thought that's what I thought, and then the problem started when we introduced solid, and he was choking. He was just choking. And I always like to say that my plan was that he was just gonna eat puree till he's old enough to realize what's good for him and not. And then we met Whitney, and that was a complete a game changer for us. And I'm watching the presentation, and I'm just getting flashback. We went through all those steps from the beginning, from the spoon on the side to the jaw, because Luke didn't have a whole lot of jaw strength, and he wasn't eating anything, and he was not eating, very picky with his food. And he is the kid now that without Whitney, we wouldn't have been able to do it. He eats everything from steak to burgers, all his vegetables, all his fruits. No, not picky at all. it is like just Josephine said, you have to put the time in. So we work at home at least 5 times a week. We do it. He's used to it. At the beginning, it was a struggle. He's extremely stubborn. So we went through our phases where he will cooperate, and then there are some months, there's some phases that he's just like, no, not doing anything. So we have to make videos so Whitney can see what he's doing. But definitely you have to put the time in those exercises. And some days you have more time than others, but definitely and try to work with your therapist. So in my case, our OT and our speech and even the PT, we all work as a team together. Every month when Whitney sends me the worksheet, I email it, and we're all on the same plan. We all collaborate. Yeah, we're working on the speech clarity now. We have done a lot of things here and there, different programs, try different things, but this is one of the things that we have stick with, and it's been 5 years now, and I really see us keep doing this program for a while. We are still at trial number 4. I saw the video of the girl. I'm like, oh, so jealous. That has been our, like, where we're struggling with the straw a lot, but I really like the program. I feel like I have grown as well as mom and my knowledge, and I'm better able to support him because I understand what we're doing. Yeah, so like, do it. Come see them in January.
Mhm.
Thank you, Saran.
All right, Karen.
Hi,
You're
everyone. I am a #1 cheerleader and encourager here. I'd like to first thank the foundation. This is so amazing. I have Claire, my daughter, will turn 16 tomorrow. No, 15. I'm sorry, 15. And when we first started out, I live about 2 hours south from Orlando, and I went all the way down to Miami. I saw Sarah Rosenfeld speak in Miami, and so I went down to Miami to see a talk tool specialist after my speech therapist was like, we don't do talk tools, that's going to harm your child. And I was like, no, I want to do it. And so I went down there, and they were more familiar with people on the autism spectrum. And I just, it was just really difficult, and it was hard. And I had to I had to buy all the tools. It was so costly. And I don't know how I got to the foundation, but I think it was the one thing that got me there. And I was like, what? They're doing talk tools? What? This is amazing. They help pay for the tools? What? I just was blown away because I had worked so hard to make it happen. And here it is. And then I thought, Zoom speech, how is that going to work? And it is very beneficial. It keeps us motivated, keeps us on the right track. I get the computer and I get the camera right up there in Claire's face and into her mouth, and we figure it all out. And there's been ups and downs. I think we started when Claire was 8. Is that true, Renee?
That sounds about right. She was a little older. Yeah.
2014, I think. So we've been doing this for 7 years. And there's been highs and there's been lows. And Renee has been so supportive. I'm like in tears, like, why am I doing this? It's not working. And, you know, when you're in the trenches, sometimes it's really hard to, you know, Claire had very low jaw. Her jaw was so week, and we were doing those bite blocks forever. And I thought, are we making any progress here? And I remember Renee saying to me, we're doing all the hard part. The easy part's coming. I'm like, really? Okay. And so, you know, these ladies know our kids. They know Down syndrome intimately. I don't have to explain things. They go all over the world and teach people. It is such a blessing to have the foundation, to have these ladies willing to come twice a year, the knowledge they have. Even now at the table, I make sure Claire's feet are flat on the floor so that her body comes up. I mean, that's like basic, simple things. And I was like, oh, that's why she's not doing her schoolwork. You know, she's kind of slumped over. I'm like, oh, feet flat, get your body up. And immediately, once her feet are flat, up comes her posture improves. And it's just amazing. So Renee's helped me find a myofunctional orthodontist. And she's walked through all the steps with me. I've been really behind. You ladies are so wonderful to get all of this information so early. The pellet expanders are happening earlier. We just did that like a year ago. It's just been recent that we've done the pellet expander. And I thought, oh, this is too late. We didn't start early enough, blah, blah, blah. But it's all working and we're moving along. And, you know, we had to get teeth extracted, baby teeth extracted. We're, you know, hey, Claire, you want to come over and say hi? Claire. She's, I don't think she can hear me. Hey, Claire. She wanted to say hi.
Oh, good.
And also she's a teenager. And so I'm like, oh, that video, she wanted to just talk the whole time, you know, but ever so slowly you make progress. And also for the mom whose son is 17, absolutely. If it was my child, I would absolutely do this and not hear the naysayers. You will be surprised how your son will improve and do great. And it's fun. Claire thinks speech is so fun. Bell, whistles, straws, bubbles. It is fun. It is not a chore. She doesn't think of speech as a chore at all.
That's awesome.
Anything else, Renee? I feel like we've been through.
I think that's awesome.
You've been so supportive over the years, especially. I don't know if I could do this anymore, you know.
I can't believe it's been 8 years.
Well, thank you all for sharing, and thank you, Renee and Whitney. And we're gonna stop the recording now.